understanding, I think, is now, it's not mature, but we will know, and then comes the next step, when you start to integrate molecular work with your H&E. As of now, it's the good old H&E. Biblical stain of H&E.
Yeah. Thank you.
Thank you for your comment.
Thank you, madam. The next thing, in keeping with the theme of the Sogocon, actually, so the questions are directed to Dr. Konetti and Shilpa. So if we had to start selecting or prioritizing the markers that we should be having in practice, or we should promote that centers across India should be having, then which are the ones that you would want to suggest beginning with in a non-metastatic setting, Dr. Konetti, and in a metastatic setting, Shilpa?
Are you asking if you want to use any of these molecular markers, or just? I think whether it's MIBC or NMIBC, and this data now coming out using the Decipher even in the NMIBC setting, I think it's still important to broadly classify luminal versus basal. I think that really still helps. It's unclear whether this molecular classification will give you any idea about intravesical therapy responsiveness. For that, you may need to use other cytokine arrays and so forth, which can be predictive of response. I know we were talking yesterday about CYPRID scoring. There's another test called Oncuria, which is a different cytokine panel that Chuck Rosser has developed. So I think those can be more of practical benefit in deciding who to treat, whether BCG naive or even in the BCG unresponsive setting, before you keep retreating them with these things. So I think there is value in predictive marker use. But beyond that, I don't think in NMIBC there's a lot of use. And then MIBC, I do get Decipher routinely in all these patients, but we're not making therapeutic decisions based on them. It's more to develop a catalog of what happens, and prospectively we can decide on our own patient population what helps. One area that may really help, I feel, is really identifying the neuroendocrine subtype. There's lots of stromal infiltration. Maybe there's some indication, obviously, that they may be more responsive to immunotherapy. Needs to be still borne out, but may be helpful to really subclassify that, because and I know Shilpa is more of an expert at this than I am, I think we're going to have IO come more into the neoadjuvant setting, and it'd be really good to figure out who is going to be a candidate for that person.
That was an excellent presentation. I think for the metastatic setting, at this point, the only thing that matters is the FGFR 2 and 3 alteration variations, because we have a therapeutic intervention.
Yeah.
Ma'am, good afternoon, ma'am.
Yes.
As in breast we have luminal and basal, as in bladder cancer also now the emerging data is telling it's luminal and basal. Is there any prognostic implications as in the breast? And my second question is there any role of molecular subtyping in non-muscle invasive so that we can predict the future risk of muscle invasive?
This is the last question.
So all this luminal basal, the data was extrapolated from breast. It started with breast. So as I showed you, we can use markers like CK5-6 for basal and GATA3 or CK20 for a luminal marker, and it's just said there is some value in trying to distinguish this. As far as non-muscle invasive bladder cancers, I showed a couple of studies, and I think there are more where they have used markers, but I think it's quite difficult at this point in time to be able to prognosticate tumors. But basal tumors behave worse than the luminal tumors. That we all are aware of. Yeah.
Thank you, Dr. Divya Midha. We move on to the next topic, which is renal hilar mass, maximizing preoperative information relevant to surgeon in 2023. And to talk on this topic, I invite Dr. Rajesh Kumar Adapala Reddy, who is a consultant uro-oncologist from Asian Institute of Nephrology and Urology, Hyderabad. Dr. Reddy, you have exactly 8 minutes when I will ring the bell, so try and finish it in that time so that we have more time for discussion. Thank you very much.
Definitely. Respected teachers and dear colleagues, greetings from Ainu, Hyderabad. I'm going to talk on renal hilar mass, maximizing the preoperative information relevant to surgeons in 2023. My objectives are defining renal hilar mass, the challenges posed by it, cross-sectional imaging, 3D modeling, and other future perspectives. So what is renal hilar mass? It's a renal tumor which is in close proximity with the first order renal vessels, so it's called renal hilar mass. And so the hilar location is considered one of the high risk the radiological feature when you contemplate partial nephrectomy. There are various the biological implications of hilar mass. It tend to be higher grade, risk of upstaging because it is in close proximity with the renal sinus, lymphatics and the vasculature. It is less amenable for percutaneous tissue sampling if you want to do active surveillance of the tumor, and high chances of radical nephrectomy and more complications intraoperatively or postoperatively, such as bleeding or the urinary leaks if you are planning for partial nephrectomy. Even in the nephrometry scoring system, it has got a special mentioning. In the renal scoring system, it is mentioned as suffix H. And in arterial based complexity scoring system, it is categorized as 3H. Centrality index, that is the distance between the tumor center and the kidney center, and divided by the tumor radius. If the tumor is located in the center, the centrality index, the scoring is 0, which is high complex. Coming to the preoperative imaging of renal hilar mass, even in 2023, multiphasic CECT utility of the CT scan still holds good. In the well-done renal mass protocol has got the various phases. In non-contrast phase, you see the calcifications and you can get the baseline Hounsfield value, which is important for further differentiation. And arterial phase, once you administer contrast, it reaches the renal artery in 15 seconds, and you can delineate the renal arterial anatomy well. And that is followed by corticomedullary. Here you can see the differentiation between the cortex and medulla, where the contrast has already been reached, the glomerular filtration of the contrast has been occurred. The hypervascular tumors like clear cell carcinomas are well visualized in corticomedullary phase, whereas in nephrogenic phase, the kidney is homogeneously enhanced, and subtle, very tiny renal tumors or the hypovascular tumors such as the chromophobe or papillary are well visualized in nephrogenic phase. In excretory phase or delayed phase, you can assess the pelvic calcium system and its relation with the tumor. CT angiogram, there is a difference between conventional CECT urogram and CT angiogram, where you give more contrast, more amount of contrast, it is around 100 ml, and you give 4 to 6 ml per second, the rate of administration. And you can assess the extrarenal vascular anatomy well. Here in this picture, there is a hilar tumor and there are multiple tumors supplying the kidney. And this information is very important if you are going for partial nephrectomy. And it has become the integral part of the preoperative planning of partial nephrectomy. MRI as a problem-saving tool, it is it's mainly used for the indeterminate CT findings in patients with contrast allergies or contraindications for contrast administration. The venous thrombus, there is even in the contrast CT urogram is equally efficient in detecting the extent of the renal venous thrombus as well as IVC thrombus and differentiating the bland thrombus versus tumor thrombus. This is a case of hilar mass with a borderline renal function. We got the MRI, which shows clearly delineate the location of the tumor and its relationship with the pelvic calcium system, which is getting played upon, and relationship with the renal vein, renal artery. It is a little posteriorly located. After thoroughly studying this renal anatomy, we decided to go for polar posterior radial nephrotomy, that is a polar flip, and dissection in the Gilverney plane, and do a radial nephrotomy in the intersegmental plane and enucleate the tumor. The 3D imaging versus conventional CT angio. Conventional CT angio, definitely it gives a better delineation of extrarenal vascularity, there is no dispute. However, intrarenal vascularity, because in the short span of time, the renal parenchyma, the renal tumor, and the intrarenal vessels, everything will get enhanced. So you will have a lot of background noise. To avoid this one, we can have a 3D imaging. It is based on high quality CT images, which by the process of image segmentation by using a software. What is image segmentation? It is identification of selective anatomical structures of your interest For example, here the renal parenchyma is made transparent so that you can assess the intra-renal anatomy and relation with the tumor. Here I'm presenting a short video which is taken from Innersight Software, who provide the navigation 3D model printing tools. Here there is a renal hilar tumor. The parenchyma is made transparent. You can assess the intra-renal anatomy well. Now the complete renal, the renal parenchyma is subtracted. The venous system is subtracted. The tumor is located in between the pelvic calcium system and the renal artery. Now you can see the relationship between the renal tumor and the vasculature, and you can see the intrarenal arterial system. You can even give the preoperative 3D printing of the tumor-specific molds so that it is helpful in better counseling of the patient. And you can use the same 3D printing, 3D virtual images and getting superimposed during intraoperative period for better navigation and skillful surgery. We are in the era of artificial intelligence and machine learning. We want the details beyond the human brain interpretation. So for that, we need the further evaluation. We need to have, by extracting the data of radiological images, gene expression, and molecular studies, we can have a further details. For example, renal tumor is very heterogeneous. Few are low grade, few are high grade, few are benign, few are the highly malignant, few require active surveillance, few require partial, few require radical nephrectomy. So we need to have a good, the radiomics, radiogenomics, or molecular radiometabolomics for the further, for better assessment and accurate decision making. For the patient perspective, usually renal tumors are being detected in early stages, small renal mass, incidentally detected, asymptomatic. And you tell the patient it is in a hilar location, you require radical nephrectomy and chances of complications if you do partial nephrectomy. Naturally, patients will have over expectations. So by explaining and showing the 3D models, 3D printing or virtual imaging, you can make the patient to understand and decrease the expectations considerably. And as a surgeon, you will be confident after thoroughly assessing the preoperative renal anatomy and its relationship with the renal tumor. With this, I will conclude my presentation. Thank you.
Thank you very much, Rajesh. What do you use on a routine basis in your day-to-day practice?
Contrast CT urogram with angiography phase.
So spending time with your radiologist
Yes.
is the most important?
Yes, sir.
Okay. And if it was the second step wherein you are trying to reconstruct, because I couldn't even when you said radial, the inter-arterial
Intersegmental plane radial nephrotomy.
Yeah, that's beyond normal people's comprehension. So the other one, the inner sight one, I found it very useful, which I think if there was one take-home message, majority of us can use it, and it's not that expensive even for Indian standard. It does make it easy.
It is around 10,000 rupees per case.
Thank you very much.
Yes.
Thank you, Rajesh, for that crisp and very contemporary talk.
Thank you, sir.
So I think I'm asking what Dr. Sanjay asked, the same thing in a little different manner. So when you are doing a little complex tumor, what part of imaging from the basic to a little more advanced, if it is not there, then you become uncomfortable to, sit on the console or scrub in?
Sir, corticomedullary phase and arterial system, where we can see everything almost. If you are asking one phase which is most important, I would like, that is the corticomedullary phase, where you can see the renal arterial anatomy, and I can see the renal, the tumor, and differential assessment and relationship with others.
So a well done CT with all the phases is probably the most important
Yes.
thing which we would always have.
Yes.
And can I have a raise of hands of people who are using routinely beyond a CT scan when they're doing complex renal tumors, all the fancy technical things? So I think maybe around 10%. Yeah. Thank you.
Just want to insist upon the fact that a good quality CT is essential. Many people do 1 centimeter cut in the CT or just a triphasic CT, which is all sadly extremely low in standards. So whenever you, as clinicians, we have a chance to interact with a radiologist, and most of us have patients bringing a CT from elsewhere. So insist upon two things, insist upon high quality CT and a CD of the CT as well.
Definitely.
There is one comment.
Yes,
for
sir.
inner sight through Sogo we have negotiated. Whoever wants, it just costs 8,000 rupees.
Oh, great, sir. Thank you.
Thank you.
Thank you, sir.
Hi Rajesh, nice talk.
Hi. Thank you,
And
sir.
Thanks that you gave some time for discussion. So tell me, in a complex tumor, all these extra things which you told, are they required only when you want to do minimal invasive surgery, or do you actually need them for an open surgery? Because we are just not talking open surgery. And I think a well-done open surgery can still save the kidney and can give good oncological outcome. And do you really need these extra gadgets for that?
So better to have, sir, always, even for open cases, but not mandatory, of course.
So a few things which are important already highlighted by Raghavan. The CT we have to have our own, we have to see it by ourselves. Second is we have to decide about the treatment on information from different aspects like CT, then if possible the 3D reconstruction in intraoperative ultrasound. We should have a three-dimensional image of this thing and put it on the table, then only we can perfectly. Augmentation reality has to happen in our mind,
yes,
rather than on the table.
Yes, sir. We need to have a better roadmap always. Yeah.
Just a point of reference. All the gadgets are essential for surgery. It doesn't matter whether you do robot, lab or open, it's for surgery. And when you have a complex tumor, having as information as you can before you touch the patient is valuable. That includes an intraoperative ultrasound. Even if you don't have a drop-in probe, open surgery with just an operative ultrasound, and definitely 3D reconstruction. I do a lot of 3D reconstruction, one of the highest numbers I do, and it makes a huge difference in the operative time. At least 20-25 minutes of time has come down, clamp time has come down by about 9 minutes.
Thank you, sir.
Thank you, Dr. Rajesh Kumar.